All right. Hey, everybody. We are continuing our series on talking about the topics that we think are really important for everyone to know so that they can, start with a leg up on their peers with information that they can apply to their life to give themselves the best chance of having the health they need to live their dream life. Not only planning for what you want to be able to do in your 70s, 80s, and 90s when you've worked so hard to hopefully enjoy that time in retirement, but also, taking advantage of the time we're in right now. If you're in your 30s, your 40s, your 50s, your 60s, there may be some things that you can only do for a certain amount of time in that period of time. We want to be able to maximize that. So we're so passionate about this, and hopefully we're able to educate people. And the topic that we wanted to talk about today is weight management. So before we begin, I think Christy and I both just want to touch base on this is obviously a very important topic to our health, which we will get into, and Christy's really an expert in this area. But we do not want to imply that you cannot live your dream life if you are overweight or obese. You absolutely can, but we just also want to acknowledge that sometimes excess weight can cause us to be at higher risk of health problems that could derail, through kidney disease, heart disease, dementia, cancers, et cetera, that could derail our chances of having a dream life. So we just want to be upfront about that. Christy, do you have anything else that you want to add to that?
Yeah, I think there's such a history of bias against people who struggle with being at a higher weight than what is labeled as healthy.
Hmm.
And we're learning so much more about obesity or overweight or even weight management, whatever you want to call it, like as a complex physiologic process. And our goal here really is to um, help kind of derail that bias and dive into why it's so complex and help people understand that there's a reason why this has been so challenging to
Hmm.
manage. And then also, yeah, like you said, work on that with the goal of reducing disease.
Perfect, perfect. Well, let's get into it then. Why don't you tell us a little bit about, why does this matter? Why does, paying attention to our weight, which I think we all should be doing for reasons we'll get into, but why does this matter as it relates to our health?
So, like I said, I think the biggest wake up call here is that like this is a chronic disease management approach we need to be taking to weight management. Obesity and overweight have been linked with many of the chronic diseases that end up being the cause of end of life for someone, and and a cause for a lot of just what we call morbidity in morbidity in medicine. So quality of life struggles. So I'll talk about more like of the mechanisms of those things, but we know that from correlation studies and there's some thoughts about causation too that being at a higher weight really does put you at a higher risk of both impaired quality and quantity of life.
All right. So, Christy, I know that, we're going to get deep into talking about obesity and weight management and being overweight and what really all of us can do to, you know, keep ourselves at a healthy weight or to try to get to a healthy weight. Um, Give us some numbers. How big of a problem is this? Because I think we know that it's a big deal, but maybe some of these numbers will shed light on really just how big of a deal this issue is.
Yeah, I think the most overwhelming statistic in the US is that when you put all the numbers for obesity, overweight versus healthy weight, underweight, put those all together, about 80% of people in the US are not at a healthy weight. So that's defined as BMI is between 18.5 and 24.9. That's the healthy weight range. 1% is underweight, and then there's about 80-ish percent that are um, above 25 and above, basically. So that's kind of the most overwhelming statistic. Another thing that I think makes an impact is um, the Obesity Medicine Association, in one of their practice statements, identified studies showing that obesity is actually the second most common preventable cause of cancer. I think, like we know a lot about cardiovascular disease and obesity can lead to diabetes and coronary artery disease or blocked arteries, high blood pressure, all those things can lead to heart attacks and strokes. But cancer is another big cause of death. And the only thing that's ahead of it as a preventable cause of cancer is smoking. So it's actually projected that that's going to flip flop soon. And so for people who don't smoke, obesity is considered like the single most preventable cause of cancer. So.
That's incredible. I talk a lot about how with cardiovascular disease, we know very clearly what we can do to prevent it, and we can be very good at preventing cardiovascular disease if we start early enough for long enough. Obviously, obesity is one of those things, but cancer is often this kind of black box of, I
Mm-hmm.
don't really know what we can do. But it sounds like you're saying that by controlling our weight or improving our weight, we could be lowering our risk of, sounds like many different types of cancers.
Yeah, there's I think 13 like most commonly associated
Hmm.
obesity related cancers. And this is not me saying obesity is the direct cause. There's
Hmm.
something about the inflammatory state of having a higher body weight that can play a role in driving cancer.
Well, let's dive into that. Talk about, because I think a lot of people would be surprised that, oh, wow, my weight could affect risk of some types of cancers. And again,
Hmm.
we're not saying there's a causation, there's a strong correlation for a lot of these things. So tell us, mechanistically, how
Hmm.
does our weight impact things like cancer?
Hmm. So when I think about how obesity and higher body weights in general can cause problems, I think of kind of two buckets. The first is what we call fat mass disease. So it's like mechanical forces from the extra
Mhm.
weight, um, arthritis in your knees and your back, obstructive sleep apnea, things of that nature. A lot of it tends to be pain related, musculoskeletal
Mhm.
issues. And then so that's the fat mass or the mechanical stuff. The second bucket is what we call sick fat, which basically means that there's too much fat cells, and because of that, the fat cells aren't working right. So, for example, if someone were to eat a massive calorie load, they're like, I'm going to McDonald's, I'm getting 3 Big Macs, it's my birthday, and
Nips. We're
Nips.
from the
Yeah, sorry.
local
Keep it
nips.
local. Keep it local. Um, Banner special.
Yes.
Um, so if they were to do that over a long period of time and basically be intaking more calories than they're burning, we would call that basically a calorie excess. And initially, those extra calories get stored as fat, usually like around the abdomen, sometimes in the legs or other places. But after those spots are kind of they've reached their max, the extra fat cells have to go somewhere. So it tends to deposit around your organs. That's how you get things like fatty liver disease, around your pancreas, sometimes around the outer layer of the heart. Um, and and the fat cells then they're not only in abnormal places, but they're growing bigger than they're meant to be. And so all the processes inside those cells get super whacked out. And the main things that leads to is an inflammatory state. So there's a lot of chemicals that those abnormal fat cells release that promote inflammation. And also, they can cause like mutations. And we know that mutations are foundational to the development of cancer. There's a abnormal gene that in some sort of cell somewhere that goes rogue, and that's how you get a cancer.
Mhm.
Um, so those are the kind of two buckets I think about. It's the mechanical stuff and then the abnormal fat cells.
Christy, have you heard of like the bathtub analogy for like visceral versus
No, this is vaguely,
yeah.
vaguely.
So I think for people that it might be helpful as like a, 'cause that was pretty complex biology that you
Yeah,
described very
sorry.
well. It's so true. Like, but this is what's happening. And that some people use an analogy of like a bathtub. So we all have our own sort of personal size bathtub, if you will. And that's analogous to the amount of fat that we store. We all have the ability to
Mm,
store amount of fat underneath our skin, our subcutaneous fat. But at some point, that threshold where we can store subcutaneous fat sort of exceeds our capacity, and we start storing fat in our visceral organs. Another term for that is like our bathtub begins to overflow with water
mm-hmm,
and it gets to leak out on the floor. And just like
mm-hmm,
water on the floor can cause problems, fat that has exceeded our subcutaneous or under our skin threshold, our bathtub, if you will, has been filled up. It can then start storing fat in our organs, and that's where we start seeing inflammation and mutation. Is that a fair analogy, you
yes,
think?
that's great. Love it.
Perfect. Awesome. All right, cool. The obesity doc approves, so thank you. Um, so we've talked a little bit about, the numbers behind this. We talked a little about how it causes disease from sort of a biological and pathophysiological state and mechanism. What do we do about this?
Thankfully, there's a lot, and more so than there used to be. So I think the cornerstone of weight management, whether you're actually at a healthy weight and you're trying to maintain that, or if you're trying to change your weight, the cornerstone is lifestyle and eating healthfully and exercise. Um, Unfortunately, though, when there's a significant amount of weight to lose, those things often aren't enough. There was a study that was published several years ago that showed only about 4% of people, or sorry, so that people who do diet and exercise alone only lose about 4% body weight. And for reference, the medications that we'll get into later, like those GLP-1s, you get 15-20% weight loss. So those things are really important, but again, not enough. And the reason for that is when we start cutting calories, making a calorie deficit, we go into something what I like to call the caveman state. That's what I tell my patients. So your body has what we call metabolic adaptations to weight loss. And back in prehistoric times, when our bodies would sense a calorie deficit, it would mean something really bad was happening, famine, or if this is a survival thing. So what changes are a lot of physiologic processes, but one of the things that makes a big difference is our hunger hormones go up and our fullness hormones go down. So the minute you are doing lifestyle changes, diet and exercises, your body is sensing that and changing things to try to promote you to move less and eat more. And that like biological drive is super challenging to overcome. Like this is not you're a it's not a willpower thing. It's like literally your biology is like fighting for your life. So that's why it can be so challenging, and the medications are aimed at targeting those type of things. In terms of like specific diet exercise stuff, I always tell my patients the best diet or eating pattern for you is the one that you can maintain. The big picture thing that's important is it has to be a calorie deficit. So you need to be eating less calories than you normally do. And how you do that doesn't tend to matter. I think a lot of people like do better with high protein, low carb diets because it fills you up, but that's not sustainable for some people. So again, it's all about what can you do? And of course we want you to help fill those calories with healthful foods. Mm-hmm. But yeah, what you can sustain and having there be a calorie deficit is most important. As far as exercise goes, there's specific recommendations. But the main goal is cardio is going to burn calories, right? And then strength training is also going to help you burn calories because muscle helps burn calories and is important for a lot of other reasons. So that's the lifestyle stuff. Sky, any thoughts on that before I move on?
No, yeah, one thing that I would just love you to speak on is I feel like, especially on social media, it feels like there's camps where some people think that the answer is only lifestyle and lifestyle only, and anyone who suggests a medicine is evil. And there's also a side of camp that says, nutrition and exercise and lifestyle stuff is pointless. Mm-hmm. It doesn't work. It's about medicines. Can you maybe talk to, how you would address someone who feels like, what the heck, this person only is about medicines for weight loss, or what the heck, this person is only about nutrition, and kind of talk to, how you would respond when someone on either of those sides would counter with that?
Yeah. I think my like general overarching goal with all of this stuff is it needs to be sustainable, because this is not like a 2-month quick fix and then you're done with it. This is a lifelong process, right? So sustainability is key, and safety is key, and I think just like balance in general. This is like such a complex process that to say it's only one thing or it's only another thing, it's an oversimplification in my opinion. So I think kind of taking the like balance helps achieve sustainability and safety. That's the way I would go about talking about that, and like kind of getting into the nitty gritty. Like I mentioned, those metabolic adaptations to weight loss. That's why I think just lifestyle alone is challenging. Can be done. Like people absolutely have done it. That's great. But then, is the weight loss sustainable? Maybe, but I think more often than not, it's not. And then with medications, um, I think the reason why nutrition and exercise is also so important, we know with a lot of these, especially medications that make you lose weight more rapidly, you can also lose muscle mass. So
Mhm.
really important to be eating enough protein, doing your strength training to make sure that you're maintaining a healthy body composition. So yeah, those are kind of my thoughts.
So if I'm hearing you correctly, lifestyle is important.
Hmm.
Everyone needs to be trying it. For
Hmm.
some people, it will be successful. For
Hmm.
some people, it will not be successful. But even
Hmm.
if you go towards a medication route, there are still nutrition and exercise-based strategies you'd want to be incorporating. So it's
Yes.
really never an all or one. It's whatever helps the patient get the job done. Is that a fair summary?
Absolutely. And I tell my patients that like the medications are aids to help you achieve the lifestyle thing. So they help regulate your hunger so that you can consume less calories, or they help regulate cravings so you aren't like tempted to go for the chocolate late at night or start snacking late at night. It's helping fight back against um those physiologic responses to help you maintain what you're doing.
Perfect. Well, let's talk about some of those medications. Like,
Hmm.
someone maybe is coming into the clinic and gosh, they feel like they've tried really hard everything they can think of. They tried all sorts of diets, they tried all sorts of exercise things, whether that was before they've started working with you or since and after. And now they're at the point that they would like to try one of these medications to help with weight loss.
Hmm.
Talk to me about kind of the things that you like to use with people, what
Hmm.
medications and anything else you think per each medication that a patient might find helpful.
Yeah, so there's two big buckets that I think of medications for weight loss in. The first is pills, and the second is the injectables. So the pills in general tend to be less expensive, also less effective. We tend to see anywhere between like 5 and 10-ish% weight loss. And again, that's average. So I have people who have lost more and less than that on the pills. Um, uh, the both of them that I use are combination medications that are are used to either regulate hunger or regulate cravings or both. So it's really it's the fun thing about it, I think, is it's very individualized. Each medication has its own unique set of side effects and its own unique set of sort of therapeutic side effects. So, for example, one of them is combination phentermine and topiramate. Topiramate is an old migraine medicine that works pretty well for prevention of migraines. And so, if somebody has migraines, I think, oh, I might be able to knock out your migraines and also help you with weight loss. Um, and there's also a unique set of like, you absolutely cannot take this medicine. So when I see a patient, I'm talking with them about their holistic health to make sure that this medication is going to be safe and work in their life. The other thing I tell everybody about medications in general for weight loss is, like we said multiple times, like this is a chronic issue. It's not I treat my weight for a year and then I get to a healthy weight and then I'm done. Those fighting back responses that your body has against weight loss will still be there when you stop the medicine. So it's not uncommon for people to need to be on these medications for a long time. And I try to explain to patients, like that's not a failure on you. It's not like you're not strong enough to keep the weight off. It's like just like you would like take your high blood pressure pill or you take your thyroid pill, or like you're treating your
Yeah.
disease. And that doesn't mean you can't come off them. Like, absolutely, you could try coming off them. If you maintain the weight off, that's great. But if you don't, you just go back on. You stay plugged in with your weight loss doctor or your internal medicine primary care doctor, and they get you back on. So that's the first bucket, the pills. The second bucket is the
Christy, sorry,
injection.
before you move on, can you
Yeah.
name phentermine, topiramate?
Oh, yeah.
Can you tell those listeners kind of what your other oral medications so they can talk to their doctor about?
Yeah. So totally. So the first one, just briefly to mention about phentermine topiramate, I'd always tell my patients, if you Google phentermine, it's going to look really scary. And that's because it was one of the ingredients in the old weight loss drug, fen-phen. but it was not the ingredient that we learned caused heart valve disease later in life. It still has some risk side effects cardiovascularly. I tend to not use it in patients with heart disease. But again, like if you have a patient who's kind of on the cusp there, you have to think they're going to get some cardiovascular benefit from losing weight, right? So you just kind of have to weigh the risk with the benefit. Okay, so that's the first one. The second one is combination bupropion naltrexone. And that's a combination of an old antidepressant and a medicine that we actually use for helping patients stop drink alcohol when they have alcohol use disorder. Kind of works more on the craving center in the brain. Yeah, so that's the other one.
All right, well, let's get into the big guns. Let's talk about the injectables.
So everybody knows about these. They're the GLP-1 agonists, and I'll just briefly talk about what they are. So GLP-1 is a hormone that we naturally make in our gut, and the medicines are basically a synthetic, really high dose of that hormone. And the way they work is they slow the stomach down from emptying, so you feel fuller for longer. And they also kind of work on those craving centers in the brain. So they have a really powerful effect, like we've seen. The problem is they're super expensive. They were first used for diabetes, and then we just found out that they also help you lose weight. So they tends to be covered by most commercial insurances for diabetes, but pretty challenging to get it covered for weight loss alone. Hopefully that will be changing soon, but for the time being, that's where we're at. They're actually pretty safe. I think there's a lot of scary stuff in the media about what these medications can do. The most common side effects are a little bit of nausea and vomiting, sometimes heartburn, kind of from that stomach slowing down from emptying. And there are also some increased risks of gallbladder disease and pancreatitis. But I could explain more into that. Won't get too complex, but really, I think a lot of those things are more from the weight loss themselves than from the medications. There's a very few type of people who cannot be on this medicine, and one of them is patients with a very special family history of a very rare endocrine disorder called MEN2, or a certain type of thyroid cancer. It's not
That's
safe.
medullary thyroid cancer. There's a lot of, right? So it's just a
Yep.
very specific thyroid.
Yep. And the reason for that is the study was done in rats. Rats have the receptor for GLP-1s on their thyroid, and humans don't. So it's more of a theoretical risk, but we say like, let's not mess with it. Yeah. So that's that. Yeah, I'll pause there. Any other?
Yeah, I just think, obviously we're getting a little short on time, so let's go over some thoughts that I think are kind of rapid fire on the GLP-1s. Other common things you've seen online that about, Ozempic face or kidney disease or heart rate or heart problems. Can you just speak to some of the other things that maybe are hyped up online, but may or may not have data to support their fear mongering?
Totally. So the Ozempic face thing, I think that one's more self-explanatory. You lose a lot of fat from everywhere in your body, and your face is not excluded from that. So that tends to be what's happening there. I will mention that rapid weight loss, like I said earlier, can cause muscle loss. So we need to be on these medications, making sure patients are doing strength training and eating plenty of protein. The increased heart rate, cardiovascular disease, kidney disease, I actually think it's like quite the opposite. We have several new randomized control trials that are showing that these medications actually give significant heart disease, kidney disease benefits. And they're starting to get FDA approval for that. Another one that you may have heard of recently is blindness, a certain type of blindness. And the thought there, at least some preliminary thoughts, I think that's absolutely something we need to watch for. You tend to be taking in less stuff in general when you're on these medications, water, food, and then that puts basically your optic nerve or the nerves going to your eye at risk for not getting enough blood flow. So again, I don't think we have direct causation coming from the med, but it's something we need to be watched for, and doctors need to be aware of.
Anything about like higher glucose levels, like if someone has an A1C of like 10 or 11 and get puts on these, is there any about like rapid glucose control that affects that or no? I can't remember if I'm
Probably. I don't remember either off the top of my head.
okay. Okay, and then just as I mean, a couple other rapid fire things on them. How much weight can someone on
Hmm.
average expect to lose,
Hmm.
and any other benefits from other organs or other disease for people in certain populations?
Yeah. So, depending on the agent, you can expect to lose anywhere between 15 and 25% on average with the medications. And again, I've seen people lose nothing on them, and I've seen people lose more than that. So that's just the average. Um, we also tend to see a lot of the like mechanical problems that extra weight causes, like sleep apnea, like joint disease, improve or even go away. Like people may stop using their CPAP because of the amount of weight that they've lost. Again, I don't think that's specific to that medicine, but more from like the rapid weight loss. And then I think the cardiovascular and the kidney disease benefits are kind of the other big ones.
Yeah, so if you have a history of heart disease or you have a history of kidney disease, regardless of if you have diabetes or not, these medications lower your risk of having bad kidney outcomes or bad heart outcomes. So pretty impressive data to support that, at least in the short term, they appear very effective, pretty safe, and
Hmm.
have not just vanity purpose of weight loss, but actual real heart outcomes.
Yeah.
Christy, we have less than 5 minutes left, and I am going to give you the impossible task of touching on bariatric surgery in just a handful of minutes. So
Got this.
I think maybe the most important thing that I would love for you to address is I think, briefly the data on how effective this is or is not from a weight loss, but also other things.
Hmm.
And there's also, I think, just general people are very afraid to get this, and you kind of
Hmm.
talk about when it might be a good fit for somebody and when it might not.
Yeah, so bariatric surgery is a highly effective, very underutilized tool. So, depending on the type of surgery you get, you can expect to lose somewhere between 20 and 30% of your body weight within a year. We also know that these surgeries do a really good job at getting rid of diabetes, partially because it often involves taking out a portion of the stomach where the hunger hormones are made. So you no longer have significant production of the hunger hormones. Um, it's a big commitment. Like I will not minimize that. Usually it takes several months of meeting with psychologists, nutritionists, surgeon to make sure you're really ready for this lifestyle change. If your stomach is essentially going from about this big to in some cases about this big or the shape of a banana. And that as you might think would cause you to get fuller sooner and your life changes a lot when that happens. In terms of safety, I will say for sure these surgeries are not without risk, um, but there's such a high um, probability for benefit that if you're at a good place with an experienced surgeon and somewhere they could do something, if something did happen, um, then it's a great option.
Yeah, I think that's well said. I mean, I think it's a big commitment. I love how you said that. Big commitment, but it is so underutilized. There's so
Hmm.
many people who are having chronic health problems that if they would have had the bariatric surgery,
Hmm.
would have reversed those things. So as I said, now here again, we're running close on time, and you did a great job of bariatric surgery
No,
in two
thanks.
minutes.
Yeah.
Um, Tell us if people want to work with you, how they can work with you, and also maybe some final take home points.
Yeah, I think the take home point is um, obesity is not a willpower problem. Being overweight, it's not a willpower problem. It's a complex physiologic process, and we have a lot of good treatments for it. Um, so go see your doctor to talk about where a healthy weight would be for you and how to achieve those things. I'm happy to see anybody. I'm starting full time at Kirkpatrick Family Care in just a little over a week. Happy to take new patients, and also happy to be your primary care doctor if that would be helpful. And then, yeah, I think just overall knowing that there are a lot of treatment options, whether it's surgery, medications, lifestyle, lots of things you can find. There are a lot of options to find something that works for you.
Awesome. Well, Chrissy, thank you for sharing your expertise. Obviously, I'm biased as your brother, but For anyone who needs a primary care doctor or would like to talk to someone about weight management, I could not recommend Christie highly enough. Go check her out. Call our clinic at 360-423-9580 to get an appointment with her, and we'll talk to you guys next time.